Hi everyone, my name is Dr. Erin Buczek. I'm one of the ENT attendings, and this is Dr. Jessica Grayson, one of the other ENT attendings. Hi. We were contacted by the med school to help out with teaching you guys the HEENT exam. Just for a little background, I'm one of the head and neck oncologic and endocrine surgeons, and Dr. Grayson here specializes in skull-base surgery and sinus surgery. So my goal for this today was to give you a real-world perspective about how to do a good head and neck exam from an ENT standpoint. I realize you have a video that you're going to watch that really focuses a lot on the eye exam as well. Full disclaimer, we're not going to do the eye exam today, but we're going to focus on the rest of the exam. So in starting off with the exam, one of the first things you want to do is just look at the patient and assess their breathing. Are they comfortable? Are they struggling? As an ENT, we're really interested in airway anatomy. And so for instance, Dr. Grayson here is sitting very comfortably. She doesn't have any stridor or stridor. Stridor would sound like a high-pitched wheezing when someone was breathing. Could you maybe demonstrate? Like that. That would sound like stridor. And that would obviously be really concerning. Or a patient could be sitting forward, doing something called tripoding. This is a sign that somebody's really having a hard time breathing. So that's the first thing you want to do, is just look at the patient overall. And you can do a lot of airway assessment just by listening and not even having to look at somebody. The next thing we usually start off with is a good ear exam. And for that, we need an otoscope. You guys have seen this in your other videos, but this is the light that we use for the otoscope, and then this is what you can use to focus it. And so there's several different varieties of speculums that match the otoscope, and you want to just use that to examine the ear. So before you even use the otoscope, you want to start by examining the external portion of the ear. So we have the pinna here, which includes the helix and the lobule and the conchal bowl in the middle there, and then the entrance to the ear canal. Beyond that, we also have the area behind the ear called the post-auricular area, which includes the mastoid bone and the skin overlying that. In a patient who, for instance, has a very bad ear infection, you can have swelling and erythema of the skin, which could potentially indicate an abscess. So it's really important to not just go straight to the ear canal, but take some time to examine the entire ear. When you do start looking in the axonal ear canal and you're ready for that, it's important to use your dominant hand. I'd say most people do that. And then pull back very gently on the pinna. Some people pull up. I actually prefer to pull sort of straight back. That helps open up the ear canal so that you have more room to get the speculum in. Be very conscious of the fact that the ear canal is very sensitive. And so in this, if you bang the tip of the speculum into the ear canal, it's going to be very painful. Next thing you want to do is use your pinky finger or even a ring finger to help brace your hand against the patient so that you have a steady hand, and then pull back on the ear and gently move the speculum into the ear canal. And you want to look as you're doing this so that you know that you're not hurting the patient or that you're not colliding with the edge of the ear canal.
See the still image of the left eardrum. Please note that our demonstration was of the right ear, but this still image is of actually the left eardrum. Here you can see the malleus through the tympanic membrane, and where it inserts onto the eardrum is called the umbo. Also, you can see the light reflex that demonstrates the healthy middle ear without any evidence of infection or effusion.
After we finish the ear exam, I usually move on to the nasal portion of the exam, otherwise known as anterior rhinoscopy. As an ENT, one of my most valued tools is actually a headlight. And to be honest, you can buy these headlights on Amazon or Walmart or a camping store. They're relatively inexpensive, and you can either get rechargeable batteries or AA batteries. I think they're really valuable because what this does is allows me to have two hands free to do a complete exam. Turn it on, and voila, you have both hands free. So I'm going to ask Dr. Grayson to quickly drop her mask, keeping her nose out. And what you want to do, start with a good nose and sinus exam, is just like the other exams, start with the external portion. So we're looking at the straightness of her nose. You can sometimes evaluate for like a deviated septum, but certainly nasal trauma. We're also feeling here around the sinuses to make sure that she doesn't have any facial pain or pressure over any of the sinuses or any obvious erythema or swelling that could indicate an acute bad sinus infection. To start looking inside the nose, we're going to gently have her tilt her head back just a little bit. And we're going to use this. This is a nasal speculum. And so for this, we want to start laterally here and gently retract the nasal ala so that we can be able to start looking in the nose. And I'm focusing my light so that I can look both at her septum and then move laterally and look at the inferior turbinate. Again, this just like the ear canal exam, the speculum needs to be used very gently and cautiously because if this touches the septum of the nose, it can be very, very painful. And we're going to take a minute now to use a scope to look inside the nose to give you a better look at the anatomy there.
This image illustrates what you would see on anterior rhinoscopy of the left nasal cavity. You can see the septum on the right side of the screen, the inferior turbinate on the left, and just behind the inferior turbinate, you can see the middle turbinate.
For the next portion of our exam, we want to look into the oral cavity and oropharynx. For this, I usually like to use 2 tongue depressors instead of 1. Really commonly, folks use 1 tongue depressor and have a light in their other hand. That's perfectly okay to do. I've just found that I can be a lot more thorough when I have 2 tongue depressors, and patients find it a lot more comfortable if you use 2 tongue blades to push on the back of the tongue as opposed to 1. They tend to gag a lot less, and you have a little bit more time to get a really good look back there. So I'm going to ask Dr. Grayson here to drop her mask briefly, have her open the mouth, and here we'll turn on our light and start by looking in first the oral cavity. So what I want to do is move the lips out of the way and examine her dentition, both on the upper and lower portion. We're looking at the buccal mucosa, which is the cheek mucosa. Here I can actually see the opening to the parotid duct on both sides, making sure that that looks open. There's no evidence of infection or purulence coming out of that duct. I'll give her a break for a sec. And then we're going to look back in the oropharynx. And here I'm looking at the palate and the tonsillar fossas and the posterior pharyngeal wall. Okay? And then we're looking at the tongue as well. Have the patient lift the tongue up to the roof of the mouth and able to look underneath the mouth at the floor of mouth. And here again, you can see the entrance and the ducts to the submandibular glands here. After we're done looking and feeling around, after we're done looking, then we're going to actually palpate the inside of the mouth. First, I like to feel along the cheek here. And basically, I am feeling her cheek between the finger inside the mouth and then the finger on the outside of the cheek. And I move my way all the way around. And here you're feeling for masses, lesions, bumps, ulcerations, anything that's painful or that may feel abnormal to you. And then finally, as far as palpation is concerned, we'll feel along the floor of the mouth. And at this point, I'm able to palpate the submandibular gland and can roll it underneath my fingers and feel for any masses, tenderness, potentially stones that could be in the gland. And then finally, we're going to feel the top of the tongue here, just basically feeling for masses. I'm not going to do it to Dr. Grayson, but you can try to feel the base of the tongue very quickly. Patients who are not anesthetized don't tolerate that great because it usually causes a pretty significant gag reflex. But if you're like me and you're looking for invasive tongue cancers, that's a really important component to the exam. Now we're going to use a scope to get an even better look inside so we can show you some of the anatomy up close and personal.
This still image shows the anterior floor of mouth, particularly the ventral surface of the tongue, the lingual frenulum, the space underneath the tongue where the submandibular ducts drain, as well as the retromolar trigone posteriorly, which is the junction between the oral cavity and the oropharynx, as well as the hard palate, which is considered part of the oral cavity, and then the soft palate, which is the beginning of the oropharynx. And then in the midline, you can see the uvula. This close-up view of the oropharynx helps demonstrate some difficult anatomy. In the midline, we see the uvula. Posteriorly is the posterior pharyngeal wall, which comprises mucosa covering the prevertebral muscles and ultimately the spine. Infections back here can lead to infections in the danger space, extending all the way from the skull base down into the mediastinum. Laterally, we see the left tonsil, which is surrounded by the anterior tonsillar pillar. Ultimately, this is made up of the muscle of the palatoglossus. And posteriorly is the posterior tonsillar pillar, made up of the palatopharyngeus muscle. This still image gives a global view of the entire oral cavity and part of the oropharynx. This is very similar to what you would see on physical exam. Anteriorly, we can see the maxillary dentition and the mandibular dentition. Laterally, you can see the buccal mucosa where the parotid duct drains. Superiorly, you can see the junction of the hard and the soft palate. And note the hard palate with its raphe right in the midline. And finally, the dorsal tongue is right in the middle.
At this point, we're going to move on to the neck portion of the exam. And for this, we're mainly interested in evaluating, we consider the lateral neck and then the central neck. It's almost sort of two separate areas that we're keeping an eye on. In the lateral neck, I'm feeling for mostly lymph nodes, but also any abnormalities with the carotid artery or with the SCM muscle here. In the central neck, we're mainly feeling for the thyroid gland. We're feeling the thyroid cartilage, larynx, and trachea. And also we're feeling the submandibular glands as well, which we partially did when we did the oral cavity exam, but we're going to continue to feel for that and any submental lymph nodes here. The way I like to do this exam is actually stand on the side of the patient to start off with. I feel like you can get a much better exam if you sort of grip the SCM muscle in between your forefingers and your thumb and massage this area and roll that muscle underneath your fingers and sort of pinch. Just a word of caution, we are not putting a lot of pressure on the carotid bulb. That clearly can have some deleterious effects, but we're mainly looking for the lymph nodes deep in the neck here. So start here, and then we're also feeling behind the SCM for some of these occipital lymph nodes. Once I complete that, then I actually move to the opposite side of the patient and do a very similar exam on this side. Lymph nodes generally will roll underneath your fingers, and sometimes it can be actually hard in a patient to tell if you're feeling a lymph node or just a prominent carotid bulb. One of the best things to do is, of course, just sort of pause and feel for a pulse. It sounds like it'd be straightforward, but in a patient who is, say, maybe a little bit more obese, it can be genuinely hard to tell what you're feeling. And after we do that, we'll go ahead and move here, and I like to do the thyroid gland exam next. So I'll have the patient sit forward in the chair a little bit, go behind them, and gently press right below the cricoid cartilage and just roll the thyroid gland, or as best I can, underneath my fingertips. Of course, the best way to feel the thyroid gland is to ask the patient to swallow, which Dr. Grayson's obliging to do, thank you. And what you should feel is the thyroid gland rise when she swallows and fall back down. What you're feeling for underneath your fingertips is the lobes of the thyroid gland kind of coming up, rolling underneath your fingers and falling back down. That movement signifies to you that you're actually feeling the thyroid gland and not just normal soft tissue. If the patient has any nodules or potentially even a thyroid cancer, there's a good chance that you'll be able to feel that. And then the last thing we want to do is feel the upper portion of the thyroid cartilage and the hyoid bone right here in the midline. What you're looking for mainly is if there's any deviation to the side, or oftentimes patients will have tenderness here over the hyoid bone or the larynx if they're having voice complaints or potentially even a sign of cancer. And then we're also feeling these submental lymph nodes. Can you lean your head back just a little bit? Mainly right here in this upper triangle midline of the neck. These are where the submental lymph nodes live. Okay? And that concludes the neck portion. The last portion of the exam that we want to go over today is a good cranial nerve exam. We are not going to necessarily talk about testing smell today, but I do want to emphasize that we actually do have that capability. We can test people's smell. We're just not going to do it for you on the video. So first thing to test cranial nerves 3, 4, and 6 is actually pretty straightforward. You just have the patient look forward, look at your finger, and then ask them not to move their head, but follow your finger with their eyes. So we look up, down, side to side, and up and down, basically in an H shape. That's what you're going for. Okay, and then last but not least, we can test some accommodation and make sure that all of the extraocular muscles are moving and intact. Next, we want to look at cranial nerve 5. I found the best way to test this is to test all 3 branches of that cranial nerve. And you can just take your fingers and touch their forehead, cheek, and then around their lower jaw, and ask them if it feels the same on both sides, or if they feel or don't feel anything indicating numbness. Just go like this. Does this feel the same? Does that feel the same? Does that feel the same? I think that's important to test each branch because you could potentially have a focal deficit in one branch, but the others not be affected. Next, we're going to test cranial nerve 7. So for this, I again like to test all branches of that motor nerve. So have them raise their eyebrows up, have them squeeze their eyes tight shut, good. Wrinkle their nose up and down, and then smile and show me your teeth. There we go. So all those branches are working nicely. Do a note for that one. I do think it's important to ask the patient to squeeze their eyes shut because just closing your eyelids is actually cranial nerve 3 and won't test cranial nerve 7 effectively. Cranial nerve 8, test the hearing. You guys have already been taught how to do the finger rubbing test. I think that's good first place to start. But one of the best things you can do is a good tuning fork test. And so there's 2 tests that we like to do for this, the Weber test and the Rene test. We'll start with the Rene since Dr. Grayson turned already for me. That's okay. And the Rene test is basically looking at air conduction versus bone conduction for an individual ear. So here you're testing the right ear and then testing the left ear separately. What you want to do is take a tuning fork. Do know that the different frequencies test different parts of the hearing. So technically it does matter which type of tuning fork you have. For purposes of this exam, we're just going to use one frequency. You want to tap the tuning fork on something, usually the palm of your hand. Sometimes I like to use the sole of my shoe because I don't want to hurt my hand, to be totally honest. So go ahead and tap it. And what you want to do is put the tuning fork on the mastoid bone behind the ear and say, is this louder? And then next the ear canal, or is this louder? It's important that you don't do this and put the tuning fork immediately next to the ear canal. You want to have it at approximately the same distance as when you had it on the mastoid bone. And normal is for the patient to indicate that air conduction is louder than bone conduction. If that's flipped, it could indicate that they have a conductive hearing loss. And then the other test would be the Weber test. And here you're testing basically both ears at the same time, and you're looking to see if they can hear the tuning fork louder in one ear versus the other ear. And again, you're going to set up your tuning fork, and you're going to put it on, basically, you can put it on any bone in the midline. You can put it on their forehead, you can put it here, you could even put it on their teeth, which we're not going to do today, but you can put it anywhere as long as it's in the midline. And then you're asking them, is this louder in one ear versus the other? It should be the same in both ears. That is normal. Okay? Cranial nerve 9 and 10, you've actually already taken a look at when we've looked in the back of the mouth. I forgot to mention that, but watching the palate rise symmetrically is a good indicator The other thing that I look for is if they have any hoarseness or complaining about that, we can actually evaluate for vocal cord function, which is another indication of cranial nerve cranial nerve 10 injury. Cranial nerve 11 exam. So I have the patient put a little resistance on their shoulders and have them shrug up, which tests the trapezius muscle. And then I have them turn their head to the side against my finger and then go the other way just to test the SCM muscles to make sure that's intact. And then last but certainly not least, cranial nerve 12. I'll have them stick their tongue out. And oftentimes I'll have them move it side to side just to make sure it's working well. If they have a deficit, the tongue will deviate to the side of the deficit. And that's the cranial nerve exam.